Good morning. Thank you very much for giving me the opportunity to come for the second consecutive year here. I must say that I don't come to give this lecture, I really come to learn, and I think that out of all the courses that I've been to, this is perhaps one of the most educational courses that I've been to, and certainly the best organized. So. Today, I'll share with you what I've learned when preparing for this talk, which is the nuances of anterior and posterior cervical stabilization. These are my disclosures, which really has nothing to do with this talk. So we'll focus on the nuances of anterior cervical instrumentation. We'll talk about plate options as well as plate applications, and then we'll dive into some posterior cervical instrumentation. We'll talk about occipital fixation, C1-2, which we did a lot yesterday, and then subaxial lateral mass and pedicle fixation. We all know the success of anterior cervical fusion is dependent on many factors, just like any other surgery. Those factors include patient selections, meticulous technique, and proper selection of instrumentation is key, so you have to know what you actually put into patients, and then bone graft and fusion site preparation. Now, during residency, I didn't even know there was a difference between the different plates. I just thought that different companies had different colors and different colors of plates and different colors of screws. But it turns out that there's more to it than just one single plate. But are plates even necessary for anterior cervical stabilization or fusion? And there are two schools of thoughts, because there are some parts of the world, especially in developing countries, where they don't even use plates. So they just do standalone cervical fusions, and patients seems to do well. Some of the pros of plate applications include rigid fixation, subsidence prevention. By being rigid, then it promotes high fusion rates. It obviates the need for cervical collar, and it reduces the incidence of graft extrusion. But plates are not cheap. They do add to the cost. Sometimes they can make revisions very, very difficult. And when there's loosening of instrumentation, you can have esophageal and pharyngeal erosion as well as dysphagia. This actually was very similar to a case that I was presented to on my oral boards for my neurosurgery certification. And this is an example of pharyngeal erosion of a plate. When you think about plates, there are really just two main types. There's either a fixed or static plate, and there are dynamic plates. So the ones that most folks would use these days are still the fixed or static plates. But you have to know something about dynamic plates and some of the theoretical and conceptual ideology behind dynamic plates. So the concept is that anytime you do an interbody fusion, anterior cervical fusion, there is some controlled subsidence or settling that occurs during the fusion process. And dynamic plates, by having these slotted channels within the plate, allows the plate to participate in the load sharing capabilities, and also prevents stress shielding. So the proponents of fixed and static plates argue that it provides robust initial rigidity, which I definitely agree, and that's my preference, especially for trauma. And by being so rigid, then it prevents excessive settling. But there are some bad attributes to it, which are it prevents compression and load sharing of the graft. Dynamic plates, on the other hand, allows for settling, as well as it allows for participation of load sharing abilities. But the bad side about dynamic plates is that it does sometimes can cause excessive settling, which can lead to peridisc ossification, which I'll show some examples of, as well as segmental kyphosis, foraminal stenosis, and implant failure. The folks that love dynamic plates often will quote this study, which is a biomechanical study that compared fixed plates versus dynamic plates in a one-level corpectomy cadaveric implant. And what they looked at both load sharing as well as rigidity of the construct. And if you look here, when the corpectomy cage has no subsidence, the load-sharing ability of a static plate versus a dynamic plate are very similar. But the moment you induce even 10% subsidence into the construct, now look at what happens to the load-sharing capabilities of a static plate. It drops significantly down. The same observation is seen when, in terms of the construct rigidity and in preventing flexion and extension. So this is a study that most dynamic lovers will quote in terms of the biomechanical theoretical support for its use. The plate strength is dependent on the geometry of the plate as well as the cross-section area of the plate. So the areas where you have most holes in the plate inherently will be your weakest areas. And so that's something to keep in mind when you're considering, when you're considering your plate of choice. But the bottom line is there is no conclusive evidence that one type of plate is superior to the others. Many studies have been done, and there's still no really right answer. So ultimately, it's really dependent on the surgeon. So a few thoughts about anterior plating and cervical corpectomy. Oftentimes you see x-rays like this where folks would do 2, 3, 4-level corpectomies and really place all their money and bets on the anterior plating providing sort of their rigid supports. And inherently, these constructs will fail. And the reason why they fail is that a corpectomy, multi-level corpectomy construct like this does a very good job with axial and compressive loads, but we all know that multiple forces are applied to the spine, such as shear and translational force. And what happens is that at the bottom, I'm sorry, I keep skipping this here. At the bottom of the construct, this area experiences significant shear and translational force, and that causes then migration of the graft, and it causes failure of the screw bone interface. And so if you're going to do a construct like that, just by adding just one fixation point to it significantly decreases the amount of shear force and really increases the rigidity of your construct. So this is Dan Rue's, one of his favorites construct. Oftentimes, if he's doing a multi-level corpectomy, he would just do ACDF above or below to really add another fixation point to it. This is another case that he did, this is a 4-level corpectomy. So it's a corpectomy, and just patient seems to fuse very well with just the anterior plate. Now, I would advise that I'm not advocating for you to do this. I will never do this personally, but you just have to keep in mind that the Rues and the Lankies and the Shaffreys and all those guys oftentimes can get away with stuff that you can't get away with. That's just how it works. A construct like this with a buttress sort of plate design is horrific. You should never do this because if the buttress plate kicks out, it can lead to tracheal compression and airway compromise. So this is a very bad idea. Do not do it. If you're going to do it, please make sure you add posterior fixation. So what's wrong with this construct? Anyone? Too long. All right, so the plate is too long. And so keep in mind, this is a subsidence plate. So this is a dynamic plate. And you can see once the graft settles, what happens is that the plate essentially translates and starts getting into the disc space above and below. So you get peri-disc ossification. So peri-plate ossification occurs when the plate is too close to the adjacent disc. Ideally, the plate must be greater than 5 millimeters away from the disc space. You have to take this into consideration if you're going to use a dynamic plate, because the moment you start to get the early subsidence, you have to calculate that distance into your construct. So again, keep that 5 millimeter distance in mind. So this is an example of an immediate post-op image. Everything looks beautiful of a subsidence plate, but then you look at the 1-year follow-up where the plate is headed. All right, so we'll switch to posterior cervical stabilization. Any questions for anterior cervical? Pretty straightforward. So posterior cervical stabilization is more powerful and versatile than the anterior, but then you pay for it with more complications. So high incidence of wound dehiscence and wound infection and more blood loss. To me, the instrumentation-related complications are really technique dependent. So doing the wrong surgery on the wrong patient or even the right surgery on the wrong patient ultimately will lead to failure. I mentioned this before yesterday. When you're doing posterior cervical stabilization, you have to know the patient anatomy. Every patient is different. You have to study the preoperative CT and spend time before you go in there instrumenting these patients. There are several options for occipital plate fixation. So the most common option that the people use there's occipital plates, but some folks can use occipital clamps and then a unified plate rod construct. The key thing to remember in occipital fixation is you have to identify the midline keel, and despite what this image shows, try to get a bicortical fixation, which is biomechanically stronger. When you're doing occipital fixation, try to identify the superior nuchal line as well as the inferior nuchal line, and you want all of your instrumentation to be concentrated in between those two lines to get the best biomechanical rigid construct. So what if you have a patient that's had a large suboccipital craniectomy and you still have to do occipital cervical stabilization? What are your options? What type of screw is this? Make Juan Uribe proud. All right, occipital condyle screw. So we should practice this in the lab. You have to learn how to do this because one day you'll be forced to do this. So the technique, this is a paper that Juan Uribe published a few years ago, and that describes the technique of achieving this fixation. So you identify the medial margin of the foramen magnum. You go about 4 to 5 millimeters from the medial border of the foramen magnum. And then you go about 1 to 2 millimeters rostral. You aim your screw about 12 to 22 degrees, and then your rostrocaudal angle is about 5 degrees cranial. You don't want to go too superior because you end up in a hypoglossal canal if you do that. But it's a salvage screw technique that you may want to have in the back of your back of your mind. If you're going to do occipital cervical fusion, structural graft is critical. You just can't throw bone grafts in there and think that you have occipital, occiput and C1 fusion, rigid fusion mat construct. It won't happen. So putting some kind of structural graft will always help you. And I'm going to just rush through because we spent a long time yesterday on C1 and C2 fixation, but there are two techniques, the notch technique versus the traditional technique. If you're going to do the notch technique, you have to make sure that you don't have this anomaly that Dr. Kazami pimped you on yesterday, which is the punticulus posticus. This is also the point that Dr. Okonkwo was making yesterday, so I made a comment that if you're trying to preserve the nerve and you want to get better visualization of the posterior of the lateral Mars of C1, you can burr some of this bone here off the inferior portion of the posterior arch to give you better visualization. But his point was that if you have an anomaly like this, you may get in trouble. You may burr straight into the vertebral artery. So you have to pay attention. This goes back to my point. You have to pay attention to the patient-specific anatomy and know exactly what you're dealing with. C1 trajectory is key because if you put the screw in the wrong area, especially if you're achieving bicortical fixation in C1, which is ideal, you have to know what is at risk. So I'm going to ask any volunteers to tell me, so assuming you choose this trajectory, what are some of the things that you can hurt if your screw is too lateral and too long? Carotid. What else? Hypoglossal nerve. So the hypoglossal nerve sits dorsal to the carotid, and you can hurt it as well. What if you take your starting point is too superior, and you aim your hand to rostral? What can happen? Where will your screw end up? If your angulation is too high. Anybody? What joint sits above? What does C1 articulates with? occipital condyle C1 joint, so the patient can have postoperative pain as well. You can see that when in doubt, always aim medially, because it is almost impossible, in my opinion, to get a spinal cord injury when you put in these screws on. I mean, you have to really aim medial to really hurt the spinal cord. So when in doubt, drop your hand medial, and you should be safe. This is an anatomical specimen showing you the relationship of where the carotid artery is in relation to the C1 lateral mass. And you can see if your screw is, if you put a screw in that has a lateral trajectory and long, you can see how you can easily hurt the carotid artery. So you always have to aim for a medial trajectory to be away from the carotid, as well as the hypoglossal nerve. All right, I'll skip through this because we talked about it yesterday. All right, let me go back to this. I made a comment yesterday that, especially for when you're starting out doing C1-2 fusions, you don't want to limit yourself with the exposure. You want to give yourself a generous exposure. I'm not saying you have to have a very long incision, but make sure that you're not fighting the tissues when you try to put your screws in, especially if you're trying to put a pars screw where you have to drop your hand. If you're fighting the tissues too much, it will force your hand more inferior, and you end up hitting the vertebral artery. And so you want to be generous with your exposure and make sure that you're comfortable doing it. Second point is I always advocate that you have to find a C1-2 joint, pack the joint with bone graft to achieve fusion. And I know there's two different schools of thought in terms of what to do with a C2 nerve root. I'm not a proponent of cutting a nerve root. I think that you can still preserve the root and still do an elegant surgery on that. So I know a few folks discuss just taking a bovie and cutting the root with a bovie, but I would encourage you have to learn both techniques. And today in the lab, just learn how to put the screw in without having to mess up, without having to cut the root. It still can be done. Keep in mind, though, that by preserving the root, you don't necessarily prevent occipital neuralgia. You can still get it. Some folks even say that you get it even more if you preserve the root. I'm not sure if that's true or not, but my practice is that I always preserve the root. I work around it, and patient seems to do fine. So this is what a C1, C2 construct, the harms constructs look like. So this is more or less like a C2 pars pedicle screw that Dr. Akonko mentioned yesterday. You can always tell this is a pars screw because the pars screw typically will end at the posterior border of the C2 vertebral body. That's how you tell. You have to know how to put translaminar screws. Can save you a lot of times, because sometimes you have no pars and you have no pedicle because of a high right vertebral artery, and you have to know how to put translaminar screws in, which can be very helpful. And then what if screws are not feasible? Then that's when you resort to your Galli and your Brooks-Jenkins techniques, or the Hani-Muglu technique with inferior and superior hooks hooked to a rod. Lateral mass fixation is pretty straightforward. I won't really spend too much time on it. There are many different techniques. The thing to do is pick a technique that works for you and just stick with it. The technique that works for me is the marginal technique, because it allows me to really stay lateral and away from the vert and the nerve, and also to stay away from the joint by aiming parallel to the facet joint. And then for folks doing cervical deformity, there are times when you don't have any lateral mass, or the fixation points in lateral mass are not very good, and you have to resort to cervical pedicle screws. So you have to have an idea of how to do this, both freehand as well as with fluoroscopy or navigation. There are many techniques that have been described in terms of doing this. The one technique is the funnel technique, where you do a hemi-laminectomy or laminopharaminotomy and feel the medial border of the pedicle and then drop your screws. Or you can do this another funnel technique where you bite off the lateral mass and then find a cancellous channel for the pedicle and drop it that way. Either way, I think that if you're going to do this, fluoroscopy, both AP and lateral, can be very helpful in that. Abumi probably has one of the largest series in terms of doing cervical pedicle screw fixations, and they've actually reported very good success rates with it, with low complications. But keep in mind that, like I said, some folks can get away with stuff that you can't get away with. If I put a screw in the foramen like that, the patient would be dead. But in this series, this patient was asymptomatic. So, Lenke always said in fellowship, it's better to be lucky than good, but it's best to be good and lucky. So that's the end. Thank you.
Isaac, great talk. Can you go back to your early multi-level anterior cervical slides? So that was a very good talk, by the way. Thank you. Difficult challenge. The question I have is, when we see these actually I have two questions. When we see these multi-level anterior cervical constructs, go back a little bit more. Yeah, something like that. What non-union rate do you, or should our fellows quote their patients? Let's say you want to do a 3-level ACDF. What is the ethically best scientifically founded non-union rate they should tell them with an anterior procedure?
Yeah, so for 1-level fusions, typically about 3 to 5%. 2 levels, typically I quote my patients 10%, but then when you start going to 3, 4 levels, it's as high as 50%. So 30% for 3 levels and up to 40 to 50% for 4 levels. So it exponentially goes up significantly with the more levels you do.
Do you still use autograft, like iliac crest autograft?
In my practice, I do not.
But it does have a higher published fusion rate.
Yes,
would you agree?
But it has a high morbidity too.
Okay.
Do you use that, Jens?
Iliac crest? Yes,
Yeah.
I do.
How often?
Probably once a year, honestly. I hate doing it. I think it's, frankly, also necessary educationally to show fellows how to do it properly with a saw, not with an osteotome, to not crack the bone. But these are recalcitrant smokers. I am very reluctant, for obvious reasons, black box, FDA, etc., to put BMP into the front. And the only other option in my decision-making is to go posteriorly for an adjuvant fixation. So if there's a patient where I truly just want to stay anteriorly, the two Appalachians are ganging up on me. I'm not afraid. I'm absolutely not afraid. I'm ready. The Washingtonia kingdom will stand. No, but so these are, iliac crest still work and works very nicely, but we should know how to do it, and we should realize that the actual complication rate from iliac crest harvesting is about 10%, and that's staying away from the anterior iliac spinous process, skin folds, infections. It's really remarkable. So yes, I do what I say should be done or could be done in healing impaired patients, and it does work. It does heal better. Jim had a comment.
Oh, yeah. Oh, just real quickly, there's a guy named Bob Heery, who you guys might know or not. Bob's kind of funny because cutting edge 1970, as we said before, he loves autograft and still today believes that patients do better with autograft versus iliac crest. He's the guy who actually wrote the paper about the morbidity of iliac crest, depending on who asked the patient about morbidity. Now, with that being said, and a lot of us lived through the period of, it was me as an intern and doing a kind of exploratory, it was like you were searching, you had no idea what the hell you were doing, and you were in the pelvis, taking a mallet and hacking through someone's pelvis to get a piece of bone graft. But I do it probably just like you, once or twice a year. And if you go back and ask the patients, you make a small incision, you do a periosteal dissection, I don't think the morbidity is as bad as it's marked out to be. So I think, the world is a pendulum, and I think we trashed it for the longest time, and I think some people are coming back. Now, with that said, I'll give you the microphone in 1 second. I'm just trying to take every one of your points. Wasn't it nice to see your follow-up on some of your patients, Steve?
Reached out a couple weeks ago and said, hey,
it's nice that guy
know what you've been up to.
The guy could brush his teeth and clean your plate at the same time.
So question 2, yeah. Isaac, devil's in the details. So I actually had the privilege, this is name dropping of the worst type, to see the great Professor Wolfgang Kaspar from Erlangen operate and to show me how he did anterior plating in the neck. And he had a very crude but extremely visionary plate, and what he really did to make this work was bicortical fixation. So when I see failed hardware, I frequently see like a 16-millimeter screw and no bicortical screw. And the manufacturers give us nice locking mechanisms of all sorts of refinement, but wouldn't it be a better idea, and what are your thoughts on routinely seeking a bicortical purchase in the caudal anchoring point where you, with your nice biomechanics, showed that the main toggle forces apply?
Yeah, I think conceptually it makes sense that it could it could provide some more rigidity, but I just haven't seen the biomechanical study that it can really still hold it without posterior fixation.
Okay.
Justin Smith did a really nice, published a very nice paper using VA data. And so it was a very large sample size of national VA data and looked at the failure rates and pseudoarthrosis rates in corpectomies. And that the conclusion was that if you do a 2-level corpectomy, you need to back it up posteriorly because of the failure rates. And a 1-level corpectomy, you can get away with an anterior-only approach. So to me, like that one option is, yes, bicortical screws to improve what you're doing anteriorly, but that's a 2-level corpectomy. And to me, the way to limit the risk of that particular long-term X-ray is posterior.
Yeah, I think that's a general consensus. So
just I'm going to help him out a little bit because the landmark paper came out of Philadelphia, naturally, was that it wasn't 2-level corpectomy, it was greater than 2-level corpectomy. And how they fail? They all fail in extension. And so the reason you need to back them up is actually to prevent extension so you don't have that long lever arm on them.
Yeah, the difference being in the VA paper was 10 times the sample size.
Have you guys written anything in Pittsburgh ever?
All right, thank you.
So wait. So let's go forwards quickly to the pedicle screws, subaxial pedicle screws. I want to share with you, so toggle loosening. I personally think bicortical screws are underused. This is my personal bias. And again, having a small ball probe in your set and seeking to engage the posterior cortex whilst your lowest point is in the middle of the vertebral body, I think is better. But you're right, I'm not aware of a good biomechanical, I'm not aware of any biomechanical study that actually proves that. But it's just going back to basics. I have a concern, and that goes into, this is all absolutely beautiful, and that revolves around Professor Abumi, who I like, and we've had many great courses together. I am worried about the advent of navigation devices giving surgeons the wrong sense of confidence to put subaxial pedicle screws in. So I'll ask our faculty first. Who of you, in all honesty, in the last year, so 2018, and I'll include the first half of 2019, that has put in a subaxial pedicle screw C3 through C6? Show of hands. On purpose. Oh yeah, right. We're talking about Philadelphia. So, okay. No, you do it from lateral. I know that, but no, Juan, give the microphone to Juan, if you will, please. Juan, why would you do that? And do you really just kind of do that under fluoroscope, or what would you say to a young surgeon who has
I can tell you the rationale behind putting screws on the mid-cervical area. And the reason is because I think the worst screw that we can put in the spine are the lateral mass screws. You know, the purchase is really bad. They tend to come out. I mean, maybe the ACF screws can be as good as the lateral mass screws, but really bad purchase screws. So you can have pedicle purchase. I think you build a much better construct. The question is, do you really need to have such a strong fixation point when you just backing up a laminectomy and there is not a deformity? But in cases that you have some kyphosis and you really want to keep that correction, I think a mid-cervical pedicle screw has a lot of value. The problem is obviously the risk that comes with that. But it's very interesting what you mentioned. Every time you go to Germany and you speak to one of the German surgeons, they're like, we do it all the time. Navigation is perfect, this and that, and we do a percutaneous, you name it. You're from Germany, you know, so they're very dogmatic. I have mixed feelings, but I can tell, I think I'm going to pass to Jay, because Jay, my partner, he does it a lot, mid-cervical pedicle screws. At least he's a big believer of that. Is that correct, Jay?
I don't do it a lot. I do it selectively, and for those situations where I feel like I really need extra fixation. So somebody on immunomodulators that you worry about is not going to fuse, or you really need to get an extra fixation point. I don't believe in doing it blind with navigation. That seems crazy to me. All it takes, especially with motion in the cervical spine, all it takes is a millimeter deviation, and you're looking at a major stroke. So I do with direct visualization with a laminotomy. Visualize the intersection of the pedicle with the vertebral body. And if you see that point and you see the top and bottom of the pedicle, you can very reliably take it right down the tunnel of the pedicle safely. If I err one direction, I err medially, and if I see a little bit of the drill medially, you redirect a little bit laterally, you know you're safe. I won't do it in tiny pedicles. It has to be at least 4 millimeters or bigger. And again, I don't think it's worth the risk unless you can really justify the need for extra fixation for somebody that's at high risk for failure. So that's how I use it, but I do on an occasion.
Did you say you're using a drill to cannulate the pedicle? Because usually these are sclerotic pedicles, so how do you overcome?
So I use a power drill.
You have power drill.
I use a power drill. I visualize, so I have an assistant with the Penfield 4.
Yeah.
With holding the Penfield directly on the intersection of the medial wall of the pedicle with the vertebral body.
Yeah.
I point at that point, and I'll err more medially, and sometimes even see, like I said, see a little medial breach, and then just redirect so you know exactly where you are. And doing it that way with pure, a true look and visualization, I think it can be done safely. And it has been done safely, and I'm not the first to do that, of course. The ESMIS last year, there was the German gentleman talking about percutaneous. That to me, that sounds very dangerous. Percutaneous navigation for 4 millimeter subaxial pedicle screws with a very close by vert and medial spinal cord. That makes me extremely nervous. But if you can see where you are, I think it's safe.
Yeah.
Right. Tyler, thank you. That was a very differentiated discussion. I appreciate that. Tyler, your hand didn't go up. Did I miss you raising your hand? You're known to be the voice of reason. Can you pass the microphone to Tyler?
No, so I have not done it in the past year. So I use them, but so my thought on them is why and where do we use them? And for deformity corrections, usually I'm going up and I'm not stopping at C3. And if I am, it's because I've done a front back and I've got an anterior body, so I'm okay with lateral mass screws. I'm usually extending down to T1 or T2. I'm not counting C7 because I'll put a C7 pedicle screw in sometimes. But C3 to C6, I use them in like a tumor scenario where I'm doing a short segment and I need some fixation. I tend to navigate those, but I think navigation, like anything, is a real nuanced technique. You need to be able to really feel and know what a screw feels like and know what things when you're cannulating going down, and you have to be really good with feeling screws and putting in like freehand screws to then be a safe navigator in certain things. So I utilize it, but sparingly because I don't have a need for that most of the time, right? I have very few patients where I've had lateral mass screw pull out because anytime I'm asking a lot of those lateral mass screws, I've either gone up to C2 or I'm down to T1 or T2, or I've got an anterior body, so I'm not really all that worried about it. So
Before Jim's arm gets ischemic, he has.
And this goes back to the guys that do it regularly. I just don't get it because if you look at Bobby, who's probably got the biggest series and probably technically the best at doing it, and is done. So Bami's the gentleman who, classified and defined the whole operation. If you look at his series, it's not a trivial freaking breach rate and a vertebral injury rate. Now, there's a couple of things. One, you get away with it because we know you knock out the vertebral artery in the great majority of people, it's not going to matter, right? The trauma literature shows 15% of people with fractures have a vertebral artery injury in dissection. That's number one. But I just don't get why doing it, because the morbidity is in his hands, it's around 10%, 5 to 10% if you look at his series. The risk of hitting the vertebral artery from flipping the person over and doing an ACF is about 0. So you got to tell me risk benefits while you're doing it. Now, don't get me wrong, I did it for the whole Mochasmos thing where I could say I did it, but I just can't see why you need to do it on a regular basis.
I think this is what I'd hope to have as a consensus for all of you. So no machismo, or however you want to call that, no bravado. I've seen Abumi do this, and it's crazy. He has this proprioception with his drill tip. It's like a sensorium. He has like fata Pacini particles in his drill tip, and he literally does this almost proprioceptively. But he has a very low threshold towards doing feminotomies. I personally think it's totally ridiculous why he does those sometimes, because as Jay said, and Tyler, there are like tumor cases or post-laminectomy dysplasia patients or something like that where you are desperate for some extra fixation. But as a routine measure, I think we should probably really ignore that, even if the temptation looms so high that we have this false sense of security from modern day navigation. A fair consensus, Kojo? I agree. All right. Thank you, Isaac.
Thank you very much.